and welcome to the Davies Use Case webinar being presented by Memorial Hermann on clinical decision support. This is a Davies Award-winning use case for the value of health IT. My name is Arnold Simmons. I'm the Manager of Quality and Patient Safety. It's my pleasure to moderate the presentation. Core to the HIMSS mission is promoting the use of health IT to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and IT-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health IT enabled care delivery. So it's my pleasure to welcome our speaker from Memorial Hermann, Siraj.
My name is Siraj Anwar, and I am the Associate Chief Medical Information Officer for the Memorial Hermann Health System. I manage operations for the system with my two CMIOs for inpatient and ambulatory, respectively. It's both an honor and privilege for me to be presenting here today on clinical decision support, which is one of our case studies for the 2017 HIMSS Nicholas E. Davies Enterprise Award of Excellence. I'll first do a brief overview of the Memorial Hermann Health System and our journey to becoming a high reliability organization and a pivotal role in our day-to-day work. I'll then case study that focuses on clinical decision support. Memorial Hermann Health System, when you look at our core facilities, there are a total of 15. We have 11 acute care hospitals, 1 children's hospital, 1 orthopedic specialty hospital, and 2 rehabilitation hospitals. Now, I won't read out all of the numbers here in the detail, but the key takeaway here is that we're quite big in terms of clinical operations, and we have over 25,000 employees that help coordinate the care directly or indirectly that is provided throughout our health system. Find out that these numbers are from our fiscal year 16. When you look at what we provide, we serve the greater Houston metropolitan area and its surrounding suburbs with around 292 care delivery sites. Grow as Houston expands, and we see opportunities for providing care to our community. Part of our past fiscal year, the numbers again show how busy we've been. We've had over 3,300 life flight rescue missions, which is Memorial Hermann's signature air ambulance program and the only one in the Houston area. We continue to make progress with several quality initiatives, a few of which are reducing our surgical site infection rates, increasing our compliance with sepsis guidelines. We have also given out 32 Certified Zero awards across the organization. Now, I will actually cover Certified Zero awards in more detail in the subsequent slides. It is paramount to what we do for our patients and is also a competitive advantage for us. We have received numerous awards, notably the John M. Eisenberg Patient Safety and Quality Award and the National Quality Forum Quality Healthcare Award. And more recently, one of our acute care hospitals, the Sugar Land campus, won the Malcolm Baldrige Award as well. We're really proud of all of our accomplishments, but we know that we cannot pause or rest on our victories and laurels because This journey to providing high-quality care is an everlasting journey that we will continue to take. I also Memorial Hermann Accountable Care Organization. Now, what the Accountable Care Organization allows for us to do is to integrate a pluralistic physician model comprising of employed, contracted, and affiliated physicians, and that is what you see up there as MHMD. Memorial Hermann Accountable Care Organization assumes varying degrees of risk for 1,000 members that are shown here. We have our own healthcare plan as well, and in addition, we cater to the needs of the various commercial plans. Can you wanted to go over Memorial Hermann's journey to becoming a high reliability organization? Back in 2007, we decided as an organization that we wanted to become a high reliability organization. Much like the industry and the nuclear aircraft carrier. Our went on the national stage and said that this is what was going to happen. We're going to become a high reliability organization. So just like any good organizational team does, we actually worked on it and we're making it happen. We began identifying events that should never happen, what are commonly referred to as never events. At Memorial Hermann, we actually term them as zero events. And these zero events, we were looking for opportunities where these zero events would not occur for 12 consecutive months. And these zero events have to be what we call a certified zero category. And when this was achieved at any one of our many hospitals, we would give them what is called a certified zero award. Now, this term was coined by us, and this is what a certified zero award looks like. In this example, this is the zero iatrogenic pneumothorax for 12 months, certified zero award that was given out to one of our hospitals. And we continue to give these out to all of our facilities as and when they're achieved. And over the years, we've given out 263 certified zero awards. This list here is all of the certified zero awards that have been given out. I've actually highlighted the 3 here that pertain to some of the other HIMSS Davies Award case studies that are related to the certified zero award. That our staff have towards patient safety. Sorry there, I don't know why. Okay. I thought of sharing this photo that I took while visiting one of our facilities. I walked into a hallway and I found this entire wall filled with certified zero awards. Just an assertion for me that our facilities are truly proud of achieving these awards. Of the Memorial Hermann Health System and should set the stage for going over our case study now. The key takeaways from the overview should be that we're big and complex, but the core tenet of our business is around providing highly reliable care for our patients. And we have worked hard over the past several years to inculcate this into our organizational culture. So going is focused on clinical decision support and how we have implemented, governed, and monitored it to provide value for our clinicians and patients. I will decision support as CDS in the subsequent slides, just to make it easy on myself. We'll be covering on CDS. I'll begin with an overview of CDS, talk about the governance process around the management of CDS, then briefly tools that we use here at Memorial Hermann. I'll also talk about why and how you measure the impact of CDS, and finally show some examples of optimizing. Exact question back in 2006. It was, what is clinical decision support? that I picked up from HIMSS and the Meaningful Use Program. I'm not going to read out each of the definitions, but I've highlighted the key words in both of these definitions, like system, process, people, and information. And in my mind, I see clinical decision support as a tool. It doesn't have to be an electronic tool that coalesces or collates information and provides it to the clinician in a timely manner so that they can make the best decision for the patient. Decision support, I joke around with my fellow clinicians that it's because we have a very short attention span, and that's what's depicted in this cartoon. It's actually one of my favorites, so I thought I'd share that. But the real reason we need clinical decision support is very aptly described here by this quote that was from an article by Dr. Ed Eddy back in 1990. And he said that the complexity of modern medicine exceeds the inherent limitations of the unaided human mind. So when you take that into perspective, on a day-to-day basis, we have clinicians who are dealing with thousands of pieces of data, both electronically and could be on paper as well. And they need to collate that information to make decisions for our patients. And we know that that is quite burdensome. So that's where clinical decision support is needed. Decision support, well, it's for several reasons. The first of which is patient safety, and specifically for the prevention of adverse drug events. And that will be the focus of my presentation here and how we're using it, how we're using clinical decision support for prevention of adverse drug events. But clinical decision support can also be used to provide treatment recommendations. It can also be used for cost containment, to prevent wastage or duplication of medications, of lab tests, of diagnostic tests. It can also be used to improve reimbursement. More specifically, CDS could be used to improve documentation of the severity of illness for our patients. And then finally, Meaningful Use Stage 1, when it first came out, it stipulated that we shall all use clinical decision support or some form of it, and that's why we do it. About adverse drug events, 1,000 people approximately are injured or die annually from adverse drug events, and the patient ends up spending 8 to 12 days longer in the hospital as a result of an ADE. And the cost can range anywhere from $16,000 to $24,000. 9.7% of ADEs result in permanent disability. Now, I didn't make up these numbers. These numbers were actually referenced from these landmark articles and publications, one of which is the most prominent, the Institute of Medicine to Err is Human publication. And it really brought to the forefront the significance of adverse drug events in our healthcare environment. When in support, the first thing that comes to mind are alerts, and that's what we're seeing here, but there are lots of other intervention types that qualify as clinical decision support tools, and this is a list. The first one is your relevant data presentation, or the ability to show data in flow sheets so it's easier to track trends as well as for surveillance. Order creation facilitators, this includes order sets and order sentences, which make it easier for the clinician to order the right thing. Reference information is the ability to provide info buttons or web links embedded in the EMR so that the clinicians can access information in an easy manner, and that fits into their workflow. We then have the documentation templates, which make it easy to document information such as patient history or the visit notes. And then finally, protocol support, which allows the clinician to follow certain pathways or multi-day pathways. So that's right. There are certain things that you have to do. There are certain effects that you want to look for, and these are the effects that you will see with a good CDS. Of course, you will see CDS. And we'll talk a little bit more about what success means and how you measure it. But a good CDS also has justifiable override. So we do want to allow clinicians to make that clinical judgment. We should have the ability to identify provider non-adherence with a good CDS. And then you want to be able to identify or predict unintended adverse consequences as a result of your CDS and account for them in your design. We refer to when we're talking about CDS, the 5 rights. Again, this is a reference from a work that has been done back in 2007 by Dr. Osheroff. I've had the privilege of working with him on several CDS projects. But what the 5 rights stipulate is that you should be able to provide the right information, which means it needs to be concise, accurate, informative, and current. And you should show that information to the right person at the right time so that it fits in their workflow through the right channel. So if you feel like an alert is the thing to do, please make sure that an alert that interrupts is important enough to interrupt a clinician. And then finally, the right format, so that the information that is presented to them, it should be easy to understand and it makes it easy to do the right thing. Another implementing CDS into any healthcare organization is to make sure that you have a good governance process. At Memorial Hermann, we have the CDS Oversight Committee, which meets once a month, and the role of this Oversight Committee is to review our monthly operating report for all of the CDS rules that we have in our production system. We the firings, the number of patients impacted, the alert acceptance rate, and then the last thing that I've highlighted in red is the good catches. I'll actually cover good catches in more detail and how we track that and measure that. But this committee also reviews all new CDS requests and help us prioritize, as well as this committee receives updates from the CDS team on previously prioritized and approved requests. When you that committee, we have the key operational stakeholders. So we have physician, nursing, lab, pharmacy, quality and patient safety representation. We've also included the risk management folks, and then, of course, the information systems division. We have the medical informatics team, the application and technical teams, because they're the ones who will be doing most of that work. Alerts and advisors that we have here at Memorial Hermann. The basic CDS tools that are available for medication management. So drug allergy checking, drug-drug interaction checking, and drug duplicate checking. We then have duplicate order checking, which is slightly different from drug duplicate checking because that's for the non-medication orders. We do not have duplicate order checking turned on for all orders in our system. We have it turned on only for probably about 6 to 10 critical orders that we feel need to be checked for duplicate orders. We then have dose range checking, which is the ability to notify clinicians if they're going outside of the recommended doses for the medications. For dose range checking as well, we do not have content built for all of our medications. However, we do have it built for the high-risk medications and majority of our pediatric doses. Our custom alerts that we build using our rules engine. Next is the St. John Sepsis Agent, which is a Cerner proprietary cloud-based decision support tool that has an algorithm to identify or to assist with early identification of SEERS and sepsis. And finally, the VT Advisor tool, another proprietary tool that allows the clinician to assess VTE risk and provides recommendations that the physicians can order directly from one tool. I'll show screenshots of each of these tools. Here's the alert. What it's showing is that the patient is allergic to penicillin, and the medication that you're entering, cefazolin, the patient might have an allergic reaction to. And the user has the ability to either override the alert, they do have to put in an override reason, or they can cancel the order entirely from this window. It looks like in this scenario we have multiple NPO orders. The duplicate order alert works a little bit differently, as you can tell from the screen here. But in this scenario also the user has the ability to either remove the orders or cancel the order, or just go ahead and proceed with ordering the duplicate orders. The only distinction with this alert is that the user is not required to put in an override reason. Alert, this is a custom alert that we built, and we have the ability to put whatever text we want in there. We can dynamically create text by using what are called substitution values. You can change the color and size of the text as well. And quite similar to the first alert that I showed, the user has the ability to ignore and continue, and they will have to provide an override reason, or they could modify the order so that the alert does not fire. I'm sorry, there. Our custom alerts actually have different triggers that we could use from the EMR. The most common ones that are available are chart open, when you open the chart, close chart when you close the chart. Order to scratch pad is when an order is being selected prior to the signature. Order signature is when that order gets signed. And then adding a problem could also be used in a trigger. And there are many, many more, but I haven't listed them all out here. This is actually the infrastructure that's used for our sepsis cloud algorithm. Is that all of our results and the patient vitals, they go up to the cloud where the algorithm is situated, and the algorithm runs through that data and determines if the criteria is met and sends back a trigger to our EMR. We decide what we want to do with it. That you can map it to, but there are adjustable trigger ranges for both SEERS and the severe sepsis alert, and we can refine these ranges accordingly based on the sensitivity and specificity. That comes back from the cloud. We have the ability to send pager messages either to a conventional pager or in the form of a text message to a cell phone. Workflow considerations for our St. John Sepsis agent alerting. And for our inpatient setting, what we've done is we've actually used the nursing workflow for notification. So they get an order and a task to show up on the orders profile, as well as on the patient access list, and you'll see the icon with an exclamation mark under SEERS and sepsis. But for the ED, because they're not using a task list, we're using a different mechanism. We are actually using the tracking board to notify our clinicians that are taking care of the ED patient. And a yellow S indicates that it's a SEERS alert, and a red S indicates that it's a severe sepsis alert. And if the MD has been notified, then that S turns into a green S. Now, what's going on with the patient? The documentation form actually shows all of the criteria that was met and why the alert fired. So they can use this information to communicate with the physician on the reason behind the alert firing. And this allows them to either take new orders or determine the next course of action. Here's what the tool looks like. Like I mentioned, it's called the VT Advisor. It actually brings in all of the patient information and walks the clinician through selecting a patient type, so it could be surgical versus non-surgical, and then walks them through identification of risk factors, both pharmacologic and mechanical contraindications, risk of HIT, and assessing the renal function so that it can provide recommendations. The clinician also has the ability to select the orders from this window and process them so that it's all done in a single window. Impact CDS alerts, you have to ask yourself, yourself this question as to what could data do for you. And monitoring is essential if you're going to be implementing CDS. So it's important that you understand what's in your data toolkit and you use all of the tools in there. And when you start to measure, there are three key measures that you should be thinking about. So the first one is functional measures. This is understanding whether your tool is working or not. So is the alert firing or is it not firing? Process measures, that's an indication of what the users are doing with your CDS. Are they overriding it? Are they bypassing it? Or are they accepting the alert and backing out and not placing that order? And then finally, the outcome measures. What is your CDS doing for your patient? I'll add those details further, but it's important that once you do start measuring this, that you identify opportunities for improvement. Emphasize any further is please make sure that you validate your data, because if you don't validate your data, you will be publishing misinformation. So years ago, approximately, we asked ourselves our data. We covered all of our alerts. We said all of our alert firings on a day-to-day basis without anyone having to extract that data manually and putting it together. And what if we could start to visualize trends in the alert firings automatically or just by looking at it? And then, of course, the good catches that I mentioned, we wanted to be able to automatically calculate our good catches for the system. And whether you have nuisance alerts or whether your physicians may be approaching alert fatigue is calculating the alert rate. For our calculation, we use number of alerts per 1,000 orders entered, and I will show you an example as well. So here's a screenshot of the first version of our CDS dashboard that actually showed our day-to-day alert firings for all of our alerts. And I've actually highlighted something here. What you see there are two rows of data. The one on top is actually a previous version of the alert that we had that was firing, so you'll see a lot of data. And on October 13th, we actually turned that alert off and created a new optimized alert. But what we noticed on our dashboard was that the old alert started to fire on October 24th. We at first thought that this was probably something that the data was picking up and was not happening to our clinicians, but when we went in and validated, our clinicians were actually getting two alerts for the exact same condition. Nobody reported to us, but we caught it here in this data. And what we found out was that on October 24th, we had a major code upgrade. So something in that code upgrade actually turned back on the old alert. We did go back in and expire it, is the term that we used, but we went back in and expired that old alert, and you'll see that it stopped firing. So we saw immediate benefit in the first few weeks of creating the CDS dashboard. So that was an affirmation that we were on the right track and something truly that we could utilize. Now here's where we are. It looks a little bit more cleaner, but here's an example of something else that we were able to identify. This data is for our drug-drug interaction alerts, and you'll see that there was a huge spike that showed up in between July and August. And we said, well, let's find out what's going on. So we went, digging for treasure. And I'll tell you, once we started to look at the daily trends of the drug-drug interaction alerts, we could quickly identify when it happened. So on July 25th is when there was an sudden increase in the total number of alerts. So we knew that that was the time frame that we had to work with to determine what was going on. Now we went one more level further, and what we found was that there were at least 3 new drug-drug interaction pairs that all of a sudden started to fire on July 25th. And these were our opioids and pain medication. And it turns out that on July 25th, we actually took new drug-drug interaction content. And we're currently working with our clinical stakeholders, primarily our pharmacists, to determine which of these are actually appropriate or clinically significant. So we're working with them to understand if they're needed or not, and the ones that we turned off, they should be reflected in the data. I wanted to share this interesting thing that we did. We actually created a CDS tool for our CDS tool. So what I mean by that is our sepsis alerting tool. Because it's cloud-based, you may have scheduled or unplanned downtimes, and we had some issues trying to identify when the sepsis alert was not working. So we actually created this tool that helps us to identify the triggers, the sepsis triggers that are coming back to us. And we actually put that on a scale, and so for every 30 minutes we said if you don't hit a minimum threshold of this many triggers, there's a pretty good possibility that the sepsis alert is down. And quite frankly, ever since we've implemented this, we have known every time that the alert is down, and we work with our vendor, communicate with them, and every time, yes, it's been identified as down. And we've used this mechanism to notify us by email. And we use those email communications to create a downtime process, a downtime communication to our clinicians and our technical operational folks so that everyone knows when the sepsis alert is down and when it's back up. Here's the high-level view, or the first screen that you see for our CDS dashboard. This is a dashboard that is currently being used by the CDS team to track and monitor, but we hope to use this with our clinicians at each of our facilities or clinical leads that can look to see how they're being impacted by the alerts, and they have a good understanding of how each alert works. But some of the key pieces of information here is the description of the alert. When it fires, here we have it as order verification. So that's an indication that it fires primarily to pharmacists. This is when it was created. Here's the alert impact that I mentioned previously. So there are 11 alerts per 1,000 orders. It's pretty low, so that's an indication that we're not getting too many alerts. Here are the total alerts that we get for the month of April. The backout rate is 100%. Total patients impacted is 44, and good catches is 44. We're almost there where I explain about the good catches, so hang on a few more minutes. But this is an indication that this alert is pretty decent. It's not firing as much. We have a very good backup percent, and it helps us understand the patients that have been positively impacted, 44. We also have the ability to drill down further. This is actually an indication or a graph of how the alert is firing on a month-to-month basis. You can see there aren't really that many significant downturns except maybe in August, but that could just be seasonal. We see that the trend goes back up, so we try to invest our time in those situations where we really see a significant change. We also have information by age because a lot of our alerts are age-based, so we felt like it was important to add some information about the age. We can also look at alerted personnel, so if there's one specific person who's getting more alerts than others, you want to maybe look at it and understand maybe they're just processing more orders for this medication. We also have the ability to look by position. As I mentioned, this particular alert is firing to the pharmacist, so you only see pharmacist position. We also have by location, so some of the alerts may fire in one particular location more than the others, as well as by a nursing unit. It just helps you to identify trends, visualize trends, so that if you need to, you could drill down further and investigate further and look for those opportunities. Manually using our data. This is actually a process measure for the St. John Sepsis Alert. It helps us understand how many of our alerts are being communicated to our physicians within a 2-hour time frame. It helps us understand how the VT advisor is being used. us what percentage of patients are actually getting the VT advisor completed and whether the clinicians are complying with the recommendations, you'll see that we're at approximately 2.1% compliance in this. This data with all of our facilities so that they can track the performance of their clinicians. Now, here's something that we did when the H1N1 influenza was prominent, we talked about in the healthcare industry. And what we did was that there was a pretty simple solution to isolating our patients. And we said anybody that you suspect to have the influenza and you order a specific lab, please make sure you put them on isolation, right? So we did a lot of education. That's what the first arrow indicates. We did a lot of education, but you'll see that it started to die down. So what we did was we actually created automated system where whenever those specific labs for influenza were ordered, we were automatically ordering isolation for the patient. And you'll see that our numbers jumped up close to 100% right after that. And that's what the second arrow is. So here's an excerpt of an abstract that we presented with Dr. Holzman. She's our epidemiologist. And what it shows is that following our intervention, there were no reported exposures to our healthcare workers. And we reduced those exposures to 0 after we implemented this. So was this effective? And does this bring value? I'd like to say yes. All right, we're coming to the good catches part now. So before I actually talk about how we measure the good catches, I think it's important to understand what our context of a good catch is. When you look at the serious safety event, in the bottom you have a good catch, which is a non-event because it was an error that was caught by one of multiple barriers. But the problem with good catches is that because it didn't happen, it may or may not get reported. Now, we're doing a better job of the reporting, but we were challenged by our leadership to come up with a process where we could quickly and easily identify good catches, and specifically using healthcare information technology. And so that's what we set out to do. So what is a good catch? For us, it is specifically related to the synchronous ADE rules, or the alerts, as we like to call them. And these are specific to the potential adverse drug event alert. So when a clinical user backs out of an alert and they do not go back in and override that alert, that's an indication to us that the medication was not ordered for that patient. Now, we've been measuring our good catches at the patient level for each CDS intervention. Here's an example of the kind of data that we look at to assess our good catches. Now, this is an alert. This is a single alert that fired to a single physician for a single patient. And this alert fires when a radio contrast study is ordered for a patient with an iodine allergy. And what you see here is that the physician saw the alert at 7:04:58 p.m. and they backed out. But they went in 29 seconds later and put the exact same order in, and they got the alert again. They backed out, but then they went back in again 20 seconds later and put in the exact same order and got the alert for the third time. Now, this data represents 3 separate alerts, but that is one good catch for us because it is a single concept, it is a single patient. So 3 alerts, but 1 good catch. So we applied this type of calculation to all of our alert data, and we started to track it on a month-by-month basis. So here's what that data looks like from 2015 onwards. And what you'll see is that the numbers are increasing. The reason for that is as we build more facilities and we build more CDS interventions, this number has been going up. And when you look at it, you'll see that we started to track a full year of data starting in 2012. And again, as I stated, the numbers have been going up for the reasons that I stated. And for 2017, I do not have the final calculations, but we were projected to hit about 91,000 good catches for the year. So if you start to look at all of the different kinds of alerts that we have in our system, I've only picked a few. And 1,506 patients do not receive a medication to which they're allergic. 909 patients have a drug dose altered due to dose range checking alert firing to the clinician. 89 patients aged greater than 65 years do not get an order for a Beers List drug. 45 patients do not receive ibuprofen and ketorolac together, which can cause significant renal injury. 21 patients have heparin order stopped within 12 hours of an epidural because of the increased risk of an epidural hematoma. Have potassium administration stopped at barcoding when the last potassium level was greater than 5.5. The last one here is probably a most important one because it's able to identify these elevations in the potassium level between the point of time that a medication is ordered to the point of time that the medication is. So here we're looking at our good catches. So on an average, our system is preventing a potential adverse event or action that may lead to a negative patient outcome every 5 minutes. What of having a robust CDS program implemented in your organization is that we've been able to receive a fully implemented score for our CPOE component, the Leapfrog Hospital Safety Grade. And that's specifically for the CPOE and CDS alert. And we've been getting this fully implemented score for each of the last 3 years for each of our unique facilities. So financial impact and correlation between potential medication errors. So to help us determine this financial impact of our good catches, we turn to a few of the landmark articles by Dr. Bates and his group that talked about the correlation between potential medication errors and ADEs, lives saved, and serious safety events. What that is stating, the bottom row, is that even if we use the most conservative assumption and say that 1 out of every 32 good catches could have led to an ADE, we are looking at the following calculation. We're looking at 76 estimated ADEs prevented. We're looking at an estimated cost avoidance of over $20 million, 79 lives saved, an estimated 946 SSEs prevented. For CDS alerts implemented, you've been able to measure the different impacts, to monitor them and identify opportunities for improvement. Identifying these opportunities for improvement, it's always important to use trends to identify these opportunities. So first look at the alerts that probably have the most numbers that are most. You may be getting complaints from users as well, because that's often the first place that we typically hear something. Like I showed in some of the previous slides, a sudden increase in the number of alerts is a telltale sign that something's not right. So you should go and look at it and identify what's going on. Make sure that you follow the 5 rights that I mentioned previously and make changes as necessary to your alert. So some optimizations that we've done here at Memorial Hermann. The first one is the warfarin-heparin drug-drug interaction alert. This is what it looks like. And in this scenario, you have the patient is already on warfarin, and you're ordering heparin, and so you're getting this interaction alert. Well, the problem is that our clinicians consider this a nuisance alert because heparin and warfarin are commonly used for bridging therapy. And we received feedback from several physicians at several venues that, could we really make this alert smarter, please? And so that's what we set out to do. And we recently received, well, it's been a while now, but we received a code upgrade, which actually allowed us to incorporate the INR value within our drug-drug interaction alerts. And so that's what we did. We, of course, worked with our clinicians to determine what that threshold value should be if we incorporate it. And after we incorporated that INR value, this is the impact that it had on the number of alerts. Just as an example, between November and December, there was an 86% reduction specifically for warfarin. Here's an ADE alert that we have for the use of dronedarone. And when dronedarone is ordered and the patient has either missing baseline liver function tests or having elevated alert was firing to the user. And there were two specific scenarios, like I described. So one on the left is missing liver function test, and then scenario 2 on the right is your elevated levels, and those are the thresholds for the ALT and AST. In this scenario, there's no baseline labs for this patient over the last 30 days, so they are getting this alert, and it's telling them to order the missing baseline lab. The helpful piece of this alert is that it actually allows the user to add the orders from the bottom, and we've actually added order sentence as well. So it makes it easy for them to order the missing baseline lab. They can also cancel the order and reconsider whether they truly should be ordering. So, of course, the message will be different. If they are elevated labs, you will see them accordingly in here. But as we started to look at this alert data, we started to identify that there might be some opportunities for optimizing. So we collaborated with our physician and pharmacy specialists, and it led to a recommendation by them. And what they said was that the bilirubin direct is not a required liver function test if the bilirubin total is already present for the patient. Now, one may ask, well, why didn't we know that when we first built this? Obviously, in oversight, we probably didn't talk to the right people. But the fact of the matter is, now we have this information and we should do something. So what we did was we actually modified the rule to remove the bilirubin direct requirement. And once we made that change, here's what our data looked like. We had an 80% reduction in our alert from the previous 19-month average. So those were the two examples of optimization. We're heading down into the home stretch. I wanted to do a quick review of the lessons learned. The first lesson is you do CDS with your stakeholders and not to them. Make sure that you have a good governance model in place to determine where you want to focus your resources and your energy, and identify those target areas and then go get it done. Make sure you apply the 5 rights. CDS, measure, measure, and continue to measure. And with that, you'll be able to identify the value of your intervention as well as identifying opportunities for optimization. And the last lesson is think about how you can get creative with health IT. There are lots of functionalities that you may not be aware of, so make sure you're talking to your vendor, make sure you're talking to other organizations, and build those networks so you can find out what others are doing, because you can get really creative with what you can do within your EMR. 2 slides. The first one here is a quote by Archimedes, who said, "Give me a lever long enough and a fulcrum on which to place it, and I shall move the world." So, EMR, then CDS is your lever. But if you want to be able to use the right fulcrum, make sure you're applying the 5 right. Some closing thoughts. Considered to be the intersection of people, process, and technology. But over the several years of working in this industry, what I've identified is that behind process are people. Behind technology are people as well. So informatics is is really the intersection of people, people, and people. But the key component that keeps all of these three pieces running together are relationships. And I cannot stress that enough. Relationships play a pivotal role in the work that we do to provide high-quality care for our patients, and is also a key component of becoming a high-reliability organization. And with that, I'm actually at the end of my presentation. Thank you.
Thank you, Suraj, for that great presentation. I want to remind folks where to go find Davies use case webinars, other Davies recordings, and where, how to apply for Davies Award. That can be found at the Davies website, HIMSS.org/Davies. So thank you so much.